Hello, and welcome. I think we'll try to get started to stay on time. I know Dr. Smith, my co-moderator, will filter in, just so that we have time for questions afterwards. I'm Stephen Bowers. I'm happy to moderate this session. Thank you very much to the SAGES Program Committee. We're going to talk about treatment of recurrent achalasia. We have nothing to disclose, myself or Dr. Smith, our moderators, pertinent to achalasia care. There are a couple factors I want to discuss that may be pertinent to recurrent achalasia. That is, the dissemination of training and robotic experience has enabled many more surgeons to perform Heller myotomy, and so there's a trend towards lower number of high-volume centers. In fact, by the NIS, 30% of all American hospitals over a 3-year period performed at least one Heller myotomy. And there's clearly a volume outcome effect in regards perioperative outcomes. There's over 50 current POEM centers, and if you look at the active experience in current POEM centers, centered on the Northeast corridor, but they account for almost 30% of all achalasia operations done at this time. So the number of achalasia operations is generally going down among surgeons. Long-term results would say that there is at least a 30% long-term dysphagia rate. This is Dr. Senday's results. And even in intermediate outcomes, that if you look at the lowest row, there's around a 20% persistent dysphagia rate. So there may be more patients who are coming in looking for options for recurrent dysphagia. There are many causes of recurrent dysphagia. Put this slide up to help with our MOC questions. Fundoplication failure is probably the best case for a laparoscopic revision. Inadequate myotomy, probably the best case for a POEM revision. But there's also fibrosis or a fused myotomy, non-dependent emptying or a sump, and reflux or mucosal stricture. And so our talks today will focus on various techniques to evaluate and treat those. Why esophageal salvage? Well, it's clear that the options for replacement of the esophagus are not great long-term. From the largest American experience of gastric and colonic conduits, about 50% of people have recurrent dysphagia or failure to maintain a regular diet over a 5 to 10 year period. So our panel consists of Kyle Perry from Ohio State, who's going to talk about endoscopic therapies. Bran Olschlager is going to talk about revisional myotomy. I'll talk about options for the dilated megaesophagus. James Dolan will talk about esophagectomy. And we're proud to have Professor Badaloni from Buenos Aires talking about alternative drainage procedures. So with that, we'll bring up Kyle.